Hi, I'm Christian Knutson. Welcome to July 2016 EMS Medicine Live. After some technical problems, we're back up and ready to start. That's us. The course is run by myself, Derek Cooney, and Brian Clemency. Obviously, for those who haven't seen this before, the idea of EMS Medicine Live is kind of bring together community and academic EMS physicians to both share information and do some board preparation as well. We chose this webinar format because it helps get people together and exchange ideas and our unique experiences and skills that we bring to the table. We're obviously using Zoom. I've muted everyone except for Mary and myself, I hope. If you have questions, forget the chat. We're having some problems on my end. During the presentations, you can't ask questions this time. But at the end, we'll open up the unmute everyone to ask questions. I am recording this session. We'll make it available on YouTube, Facebook, and somewhere else. Our Facebook, our regular webpage. If you need to find us, just Google for us, and we're usually the first 2 or 3 hits on Google's list. So at the end, we'll unmute folks. If you have any questions, we will answer them. You know, just message me in the middle, but the way we're doing it today, I only have one computer, so I can't answer questions and do the presentation at the same time. So wait to the end. We have Mary from University of San Francisco speaking today. I apologize, I didn't get your bio up today, so I'll leave that for you.
Sure.
But we are discussing mass gathering medicine. Go ahead.
Okay, great. So I'm Mary Mercer. I am the Associate Fellowship Director for the EMS and Disaster Fellowship at University of California, San Francisco. And I work clinically as an attending at San Francisco General Hospital, now Zuckerberg San Francisco General Hospital, which is the trauma center and county hospital for the city and county of San Francisco. And in that capacity, I serve as the base hospital medical director. So today I'm going to talk a little bit about medical direction for mass gatherings and the thinking and science behind how we currently plan and respond to them. So I want to give some special thanks to Drs. John Brown, who's also a faculty member at UCSF, and Katie Tataris. So John is the medical director for the city and county of San Francisco EMS, and Katie Tataris, who's one of our former fellows, who's now at University of Chicago with Chicago Fire, as well as Joshua Smith, paramedic in our system, who helped inform the content of this lecture and who also were co-authors of the chapter for the NAMSP textbook on this subject. So I have no disclosures. So the objectives for today are to define mass gatherings, to provide some historical perspective of mass gatherings and mass gatherings that have evolved into disasters, and some information about crowd science that helps inform our thinking around planning for mass gatherings. We're going to go over the principles for medical direction, planning, medical management, and disaster response. And we will scatter throughout this some case studies that exemplify some of these principles. There's a little bit of a delay here, so apologies for that. There are several references, and I have some primary references at the end of this text, but also just in terms of the content and format. There are 2 chapters from some of the major textbooks, and I apologize, Derek, I haven't incorporated your content into this, but the NAMSP textbook and Koenig and Schultz's disaster medicine have informed the content here in terms of structure, and several other primary texts from different EMS systems responses. So why do we care about mass gatherings, and why should it be part of the understanding and curriculum for EMS fellows and future EMS medicine physicians? So it's really important when thinking about special events and mass gatherings, unless they really are occurring in isolation, such as like Burning Man or something like that. Mass gatherings and special events stress the existing EMS systems. So medical director has a big stake in the game of how planning happens for these. They also have the potential to evolve into unstable mass casualty incidents due to both crowd behavior or environmental factors like extremes of temperature or other weather conditions or fire. And they are, unfortunately, in this day and age, easy targets for intentional mass casualty incidents or terrorism. So yes, and I argue that because of all of these reasons, EMS medical directors are uniquely qualified to guide their community's planning and response to mass gatherings and disasters. So the skills that you're developing over the course of your fellowship are going to help you become a leader for your communities in planning for these events. Let's define mass gatherings and special events. So both FEMA and the WHO have defined mass gatherings and special events, and they have slightly varied definitions for these, but both organizations note that they are non-routine activity. Their mass gatherings are characterized by non-routine activity, either organized or spontaneous, that is bringing people together, a large number of people. And it doesn't really matter in terms of the definition how many people, whether it's 100 people or 2 million people. Either of them could have an unstable effect on the surrounding communities. And either way, the other definition is that this gathering will strain the planning and response resources of their local communities. So the effect, the types of incidents and effect that a mass gathering can have on the community can depend on the size and the types of medical challenges and public safety challenges can depend on many factors. So one is the size of the event. So on the left, you see a picture of pilgrims traveling to Mecca for the Hajj, which is one of the 5 pillars of Islam. And on the right, you have an example of a parade of about tens of thousands of people in San Francisco every year participating in Beta Breakers. So you can understand the scale can have an impact on the local community. Next slide. The type of event can also drive the types of injuries or threats that are present in the setting of a special event. So whether it's a parade, such as a planned parade to celebrate a holiday, or a protest, a spontaneous or planned protest, such as an example here is Black Lives Matter. There can be different types of injuries, different types of patient population, and different types of threat to public safety. Versus, a rock concert, like an electronic music concert, which has a different scope of participants who have different uses of illicit drugs, which can bring in different medical challenges into the mix. Further, next slide, location can have an impact. So the planning and types of injuries and types of response for a mass gathering that is very dense in terms of the participants, such as in an enclosed stadium, can have different challenges in terms of crowd control and crowd science versus an event like a bicycle race that might be active over long distances and have a whole host of other types of injury patterns. affecting the medical response and planning. Similarly, next slide, the environment can play a role. So if an event such as extreme sports events that are taking place in extremes of temperature, like cold or heat, that will have to factor into the extent of the supplies and training for the medical personnel. Next slide. So when we think about risk management and mitigation for mass gatherings, there are 5 major principles that we focus on to help plan and mitigate response. So those are crowd control and preventing overcrowding. Similarly, controlling event access and ticketing that can help mitigate the challenges of crowds and the physics of crowd behavior. We also emphasize fire safety, prevention and response, and very robust medical preparedness and emergency response planning, understanding what the routine needs, medical needs for the event would be, and how those would scale into a larger medical response. And then broader emergency response. So this would be more along the lines of integrated public safety and disaster response. Next slide. So overcrowding and crowd control. So for hundreds of years, really, this has been a noted phenomenon from the early times of people gathering in public spaces. People have started observing that crowds have unique behaviors in response to in response to emergencies, and also just behaviors based on momentum that can generate within a crowd. So we know, since the 1800s, there have been series internationally of theater and then later on nightclub fires. So any place that requires lighting at night with crowded groups of people from China to the US, all over the globe, South America, hundreds of people, thousands of people really die every year because of not just because of fire occurring in a closed space, but because in the evacuation process, the panic that can take over a crowd can lead to very unsurprising crowd behaviors. So the deaths are not just due to asphyxiation, but due to trampling, stampeding, and crush injuries. And so in more recent years, next slide, more recent disasters have given us more information, and actually in the age of video and YouTube, a number of physicists around the world have been able to study the behaviors of crowds in more detail, and have been able to define the types of physical interactions and momentum within a crowd that can lead to different types of patterns of injury. So we define these as crowd crush, which is transmitting of a force and pressure onto the next person, which can lead either to trampling or stampeding, but also just the sheer force of human bodies pushing against each other can lead to asphyxiation injuries and death. But then there's also in recent years these concepts of crowd turbulence, which is even in the absence of of unified kind of stampeding behavior, crowd turbulence kind of defines the ups and downs of the swirl of physical momentum within a crowd, and crowd quakes, which are kind of, if you think about an earthquake, like they are actually pulses of energy and force, which are not unified, not unidirectional necessarily in a crowd in the sense that of a stampeding or trampling injury, but just when the sheer density of a crowd and movement within the crowd erupts, there can be short duration but high impact forces in a crowd that can lead to sudden trampling, or just the transmission of forces that can lead to death of the participants. So next slide. Uh-oh.
Don't do that.
Oh,
There you
yeah,
go.
thanks. So in response to these, many event planners have developed standardized procedures to try to control crowd behaviors and the sequela of overcrowding. So ticketing and controlled access points are one way to do this. So by literally, controlling the volume of the crowd, you're decreasing the potential for force to be transmitted. By separating the ingress and egress routes, so having unidirectional flow and clearly demarcated areas for people to enter and to exit, and to have good signage and easy access to areas of egress, such as stairwells, doorways, to kind of keep those access points open, because in a lot of crowd-related injuries, the people trying to access exits tend to be where panic sets in more, and more injuries are clumped near those areas. And then similarly, safety officers, safety personnel who can help control the crowd and clear communication, either with audio communication or very visible signage to help move crowds sort of in a more standardized fashion, and then clearly marked pathways. Next slide. So case study to discuss. So in 2015, there was a stampede at the Hajj, and over 700 people were killed and 800 more were injured. And this, not every year, but every few years, there have been various forms of stampedes during the pilgrimage to Mecca, and the medical response system and safety response system tries to anticipate and prevent these. This was in a setting of basically at one stop on the Hajj, there were you're supposed to throw stones at the temple of Satan or something, and so one group was trying to move in one direction to throw stones, and for whatever reason they came across because of the planning situation, they came across a group moving in the other direction. So you had bi-directional flow in a very closed space, and the momentum of the crowd with the force of people throwing kind of overcame people in front of them. And in particular, because the Hajj has a lot of elderly and frail people, it's the last pillar of Islam that people try to accomplish before the end of their life. But there are many people who are in wheelchairs or are frail in other ways who succumbed to this was classic stampede behavior that resulted in 700 deaths. Next slide. In 2010, the Love Parade in Germany, and this was one of the crowd events that had a lot of video footage relating to it that really changed our understanding of crowd behavior up until this, and injuries associated with it. Up until this time, pretty much most people believed that that most injuries and death were due to that stampede-like behavior. But in this one, physicists studied the movements of people afterwards on YouTube, and were able to see that there weren't really a unified rush of stampeding people in one direction, but there was a back and forth movement, and that's where they came up with this term of crowd turbulence and then crowd quakes, where people who, the deaths that were shown, these are outlines of where bodies were found, were not near the usual like exits or stairwells. They were sort of just randomly distributed throughout the crowds, and seemed retrospectively when looking at the films to be due to these very short bursts of force that were transmitted through the crowd. And again, this had to do with when they did an after-action review of this, it seemed that most of the challenges here had to do with poor control of ticketing and poor control of the volume of people, and then also having bi-directional flow through a tunnel without clear unidirectional flow that led to those turbulence events. Next slide. So fire safety, as I kind of alluded to at the beginning of this discussion, it's a big cornerstone for enclosed mass gatherings, particularly for theater and other events that tend to happen at night that require lighting. And there's not too much to say that's different from the crowd source, but basically any medical plan for a mass gathering needs to have a clear fire safety response if it does involve any enclosed areas. It probably should have one, even if if it's completely an open area as well. There have been incidents of people, particularly out in wildlands, who have been victim to so during Race for the Planet or Racing the Planet mass gathering events, they have had incidents of wildfires getting into the course and injuring participants. So knowledge not only of the making sure that the buildings and the structures are fire safe and up to standards, that you have an active fire response team that's on notice that an event is happening, and access to mutual aid if need be, but also being aware of weather patterns and other natural hazards in the area. Next slide. So medical preparedness is one of the main principles that we noted earlier, and this is where the medical director gets to play a more active role. So it's very important in planning for a mass gathering or special event that there is a medical plan in place, not just to anticipate the medical needs of the participants and the resources that would be needed for those, but also to understand the hazards and the risks relating to possible escalation of the medical emergencies, as well as external threats. So ways that a medical director can think to plan in these regards, or a system can think to plan, is by understanding the characteristics of an event, who the participants are, what activities are going to be done, are they old, are they young, are they doing a lot of exertion, are they is it outdoors, what are the weather patterns, are there drugs and alcohol involved, as well as knowledge of past events and local resources. So did this event strain the EMS system in years past? How are we going to respond to it this year? What have been the injury patterns that we need to be prepared for? Where is the nearest hospital? And what resources do we need to bridge the medical gap between the event location and definitive care? Again, preparing for escalating scenarios and understanding external threats. So does the volunteer or paid workforce that's going to be providing medical or public safety support, are they aware of different possible scenarios and how to respond to them? And the medical director and others need to have understanding of best practices for staffing and equipment. So does this event require EMT basics, just first responders, or do higher levels such as paramedics, nurses, or physicians need to support the event. Next slide. So again, here I'm going to give another example of the Hajj. So every year, over 2 million people travel to Mecca. Many are elderly and have many medical problems. And I think the maximum a couple of years ago was 3.2 million people made the journey. And so in preparation for this, Saudi Arabia plans 100,000 extra safety officers who are, so police forces and other security forces who are dedicated to helping control and provide safety and law and order in these areas, as well as fire suppression. And then they also add another 25,000 healthcare workers into the area. Because the journey can take some time and carries over a distance, as well as occurring in blazing sun and heat, they have established a protocol to set up over 100,000 cooling tents along the journey. Next slide. Another case study, Burning Man, which is an electronic, musical, and art community that is created every summer in the Nevada desert. And basically, Black Rock City is this area that has no population throughout the rest of the year, but they, over the months leading up to Burning Man festivities, they put together basic fire, police, and emergency medical response systems, and it's a pretty evolved medical response community. So they have a whole range of vehicles, transportation vehicles, ranging from full ambulances that can carry trauma patients in them. I believe there's helicopter evacuation capabilities for needs for definitive care, and then a bunch of these quick response vehicles, which are basically souped up golf carts. And this is not unique to Burning Man. These are common in other outdoor events that cover large distances to get first responders out to patients and victims. They also understand, so they're able to provide acute medical and trauma services from pretty sort of low-level stabilizing care to more advanced care, and then evacuation if needed. They also know their community, so there's a lot of drug use at Burning Man, and so they've created an area called a sanctuary, which they've defined as an area which is for medically stable patients who are having a bad experience in Black Rock City. And so I kind of liken it, in San Francisco we have a sobering center. So it's sort of an area for people to get away from all of the stimuli and safely come down from their high or their bad trip. So they're understanding what the medical needs of their community are and doing that in a safe way. They also, because it's the desert, they have sort of extremes of heat, that extremes of temperature, both blazingly hot in the day and near freezing at night. So that can leave a number of their participants at risk without proper medical and physical support. Next slide. So the other pillars of our principle for effective mass planning for mass gatherings is understanding emergency response. So it's really critical that this response be pre-planned. So that includes, even if you don't anticipate this event to evolve into a disaster, preparing for it will decrease your startup time should the event indicate otherwise. So that means having an incident command structure of unified command, having emergency access corridors that are maintained and protected throughout the event to facilitate quick response, and having a robust an effective communication system with multiple redundancies, including dedicated radio channels as well as cellular technology. Now, next slide. So a case study in this regard, I'm going to share story of the Chicago Marathon. I'm not sure if anyone here is from Chicago, but in 2007, some of you might remember the Chicago Marathon is in October every year, and it's pretty, usually it's relatively cool, but in 2007 there was a heat wave, and temperatures, I believe, were in the 80s, might have been even higher to the 90s, and so with a long race that was going to go over 26 miles in the heat, with the crowd that ranges from professional athletes to a lot of amateurs, there's a lot of risk associated with this for hyperthermia injuries. And so the next slide just kind of shows the medical team. But in advance of this event, the team did a lot of planning, as they always had done. Had the medical tents and response stations set up. Had coordinated city planning with multiple agencies, and then as the week came closer to the event and they realized the weather forecast, they started to make adjustments based on the anticipated weather, adding more hydration and ice to the different medical response tents. And then as the day went on, really actively monitoring the situation, having good situation awareness that was coordinated between the city agencies, so that as they started kind of with surveillance and monitoring of the conditions at each of the tents, and they noticed larger and larger numbers of people needing to drop out, needing to be treated, they eventually decided to shut down the race in the interest of public safety, and were able to do that swiftly with the aid of police, with fire, and it's relatively well accepted as a success. They did have one death, unfortunately, from that event, but the methodical nature with which the different public safety and health agencies responded and monitored the situation was an example. So, next slide. Which leads us to the Boston Marathon of 2013. So, oh, sorry, go ahead. Someone have a question? No? Okay. We can have questions a little bit at the end, but the Chicago Marathon and other marathons kind of emphasize the importance of emergency response planning, and so pretty much marathon preparedness had become pretty extensive and routinized, especially in large cities, utilizing their incident command systems. Boston's a good example. All of their, they had the luck of the event of the disaster of the IED explosion occurring at the end of the race. So it was nearby to a pretty high density of their medical tents, and then they were able to convert that routine post-race medical care area into mass casualty care. They are also, like many of marathon support in major cities now, that have accepted the importance of well-trained volunteer personnel, meaning emergency medicine trained physicians and nurses, and well-versed EMS systems. These groups were able to transition from the expected medical response, which in a normal marathon day, to trauma response. Although they had limited supplies for trauma interventions, people were able to keep cool and triage and load a number of patients appropriately. And again, highlighting the multi-agency response. Go ahead, next slide. So this brings us back to the medical director role. So what can you, as medical directors of different agencies or provider services, how can you play a role in planning and responding to mass gatherings? Say your duty is to ensure the public health and safety of the participants, and to ensure the maintenance of usual EMS needs within your communities. And so because of these duties, you really have a strong voice to be an advocate for and to participate in rigorous event and disaster planning in advance. Next slide. So you in your medical director roles, depending on the role you play, you can help determine or respond or change your local regulations, including your local and regional MCI plans. You might be involved in overseeing or approving, including modifying medical plans for mass gatherings. You can encourage early involvement of the different stakeholders in the planning process. So police, fire, the local emergency management agencies, and the local EMS response. And then you also have a role to be able to test and confirm the response and treatment systems in advance. So by advocating for functional exercises, tabletop exercises, and challenging the assumptions of your local partners. Go ahead, next slide. So in this process of planning and management, the key features are anticipating the challenges, the medical challenges you might face, preparing for an escalating event, and working with the stakeholders in advance of an emergency. Next slide. Next slide. So, and when you're evaluating a medical plan, the point of doing this is to identify the resources and strategies for response that don't stress the existing system. So, by looking at the numbers that you expect to have, the types of injury patterns that might be possible, you can recommend staffing, including first responder, BLS, ALS level, evaluation, treatment and transport options. You can identify strategic areas for on-site treatment, as well as personnel needed for that. What you can ensure that there's safe and stable communications, both telephone, radio. You can help the event ensure that the local destination hospitals are prepared and ready to receive potential victims from an escalating event, and then ensuring that there are coordinated contact numbers for the people responsible for the event to ensure real-time monitoring. Next slide. So there is some research into sort of what the best resources are for event response and event stabilization. And so in studying past mass gathering events, depending on the type of event and the participants, if it's a street fair versus a sporting event, the rate of calls or per 1,000 spectators has been noted to be between 0.5 to 2 calls per 1,000. And so depending on what the type of event is and the past experiences with that, you might recommend on-site treatment with physicians and nurses, or you might recommend different paramedic or EMT basic staffing plans. Obviously, what makes sense logically is that places that have had on-site physician and nurse response are able to utilize the EMS transport system less by treating people and allowing them to remain at the event. Also, in terms of the principle of wanting to have be able to respond to a cardiac arrest, and the same one of the standards that we hold our EMS systems accountable to is the ability to have an AED within 3 to 4 minutes. And so that means you want to be advocating for strategic placement of your BLS and AED resources. And then the other principle that in terms of defining your resources for transport is to have definitive care or hospital within 30 minutes from any place within the event. So that will determine, next slide, the type of resources you might deploy. So this is a photo of some bike medics who are participating in first responder response for a street fair. So depending on the nature of the event, you might want foot teams or bike teams in order to forward deploy your BLS and AED resources appropriately. Next slide. You also want to make sure that, in this day and age, a lot of people use and rely on their cell phones for communications, but depending on the event and the location, if there's a lot of usage of the cellular area, or if it's in a sprawling area with spotty coverage, you want to have radio redundancy. Next slide. A case study that I want to share with you that we learned from in San Francisco was the San Francisco Half Marathon in 2011, in which it had a medical plan with one BLS ambulance or one ALS ambulance for the event, but the event was through Golden Gate Park, which has kind of poorly labeled streets. People are not always sure which street or road within the park it is. So the ALS ambulance got deployed to go respond to an injury about halfway down the course somewhere in the park. And then a 36-year-old man was finishing the race and actually had a cardiac arrest and died near the finish line. And there were some first responders there, but there was no AED located at the finish line. And when the ALS ambulance had been deployed, there was no system in place to call for a new ALS ambulance as backup. And the staff at the finish line were not aware of their communication structure. So it took 30 minutes from the time the patient collapsed until they were loaded into an ALS ambulance to try to resuscitate him. Next slide. So, disaster preparedness. So basically, as the final sort of principle in planning for a mass gathering, this a mass gathering really presents you with an opportunity to check on the health of your disaster preparedness plans within your communities, and to work with your stakeholders in a less stressful way to prepare and to build those soft relationships that can help in a coordinated response if things go south. So as the medical director, you'd be assessing hazards and resources that are available in your community. You're familiarizing your team with the other public safety agencies and really getting to test your response plan and practice the incident command system. The next slide. So an example of this in San Francisco, most recently, we hosted the Super Bowl 50 and had a couple years or a year and a half of multi-agency preparation in this regard. So we had learned from past events, particularly New Year's events and some of the parades and celebrations in San Francisco for the Giants wins and everything else, that when we had a lot of celebration in the city that taxed our EMS resources, we had the need for mutual aid because of our increased number of traumas and drunken response. So that knowledge allowed us to go into Super Bowl 50 with a kind of unified plan to have a regional preparation for potential for mutual aid. It also gave the EMS agency and the Department of Emergency Management the authority to bring the multi-agencies together to test different response systems. And so we did this in a methodical way with sort of tabletop exercises and then leading up to functional exercises, both for a good day. We planned for a good day with regular medical and safety needs for the community, and then also testing a bad day. And one of the examples here was bringing all of the groups, including the trauma center, to the table, asking the trauma center, we have our mass casualty plan for our system in place. How many critical patients can you functionally receive at one time who would need operating room services? How many ORs can you run? And they had said sort of the back of the envelope that they could run 10 or that we could run 10. And then we followed that up with a functional exercise to see if that actually held true. And that was very helpful for us, both as a community and also as a trauma center, to test our interdisciplinary resources before needing to test them in real time. Next slide. So once if the unfortunate happens and a mass gathering turns into a mass casualty incident, if you've done those 5 things to prepare for crowd control, fire safety, medical management, disaster preparedness and planning, then you're well positioned to respond successfully to the event. So you're able to have situation awareness through communication systems. Utilizing ICS and unified command in advance allows you to easily scale to a response mode and understand who's in charge. And you've already tested your baseline medical capabilities for first response, and you can convert those into triage and staging for larger scale care. This is next slide. Some things, this is a sort of a funny slide from San Francisco. We've had some past mass gathering events that have gone awry that necessitated commandeering our Muni system to transport our low acuity patients. And sometimes these types of circumstances lead to innovations in care. So after having a few incidents that required using Muni for transporting our low acuity patients, the fire department worked with Muni to basically convert a few of the Muni buses into mass transport vehicles, and they get deployed for larger events, which can be either treatment places in place for things like sobering or for transporting patients over longer distances. And then finally, next slide, any event, any mass gathering should be followed by a post-event review. So you need an immediate debrief and hot wash with your respective teams to gather initial information, but a formal after-action report both within and between agencies is critical to help you and to help inform and adjust future plans, future events, and to increase overall preparedness for your community. And to do this post-event review, it doesn't need to have the event become an MCI, but this helps you prevent it from becoming one in the future. So in summary, mass gatherings and special events have unique challenges that face the delivery of medical care. And by planning for expected medical surge and potential escalating events, this is an important feature for the EMS medical director, who's well suited to participate and lead in these efforts. So thank you for your time. Who has any questions?
I'll take the first stab if you don't mind.
Sure.
I had 3 questions. For the Chicago Marathon, who made the final decision to cancel the marathon? Was that a medical director position, or is that someone in CS?
So in my reading of, there have been a couple different papers on it, and I just realized I left out the reference slide, but I'll send an updated version of the slide that has the references. But it sounded like it was a medical director decision, but it was made in conjunction with basically unified command. They had sort of a unified command set up in advance.
At the end, you mentioned that trauma services that I assume UCSF could handle 10 patients at a response, and you actually tried it out. How much could they handle what they said?
I mean, yes. So, and these are for 10 criticals. I mean, so we've tested our response. I'm actually at San Francisco General, which is the trauma center. Mm-hmm. And in San Francisco, we have only one trauma center in the city and county. So we receive the majority of trauma victims. So after the Asiana crash, for example, patients were somewhat distributed. There's supposed to be a round robin system for the less criticals. Right now, the way it's written is that after the first 4 criticals, they get distributed. Mm-hmm. The criticals get distributed to the hospital. But in in Asiana and other events, we've taken more than that, and we tend to take have sort of said the first 10, then we tested it, and we were able to, take 10 pretty much immediately to the OR, and then, work with larger numbers, so most recently up to 50, to stabilize them. But obviously your resources are limited, so not everyone's going to go to the OR.
Fair enough. And one last question. The Muni bus that was converted to disaster response, who funded that? Was that the city, the fire department, someone else?
It was a combined effort. So we both from Asiana, and then a New Year's event a few years before Asiana. They had resorted to utilizing Muni after we had exhausted all of our ambulances, and also requested mutual aid from neighboring counties. And so it's sort of I'm not going to say that it's something that I would endorse for every system, but after some thinking and planning, after witnessing that improvisation, the fire department decided they wanted to have a little bit more structure and have that treatment capability be in line with what the EMS protocols were. Understood.
I want to wrap things up. I want to thank Mary for her time today and for presenting that. It was very interesting and very useful. And I also want to thank her for working through our technical issues.
Great.
Appreciate that. And I didn't get my last slide put in, but next month it will not be Craig Cooley out of UT. We have Dr. Karad, I think, is going to be presenting something about resilience and having your providers have better mental toughness for the job they do, which sounds very interesting. So again, thank you to Mary, and hope we see you guys next month.